Where is my presentation now?
That's it.
Okay, let me just see if I can get it.
Just going to mute myself.
Okay, good afternoon. My name is Susan Cliff and I'm the Deputy Chief Inspector of Social Services with responsibility for the regulation of nursing homes. It's a pleasure to be here to talk to you today, and I'd like to thank Amanda and her team for inviting me to speak to you. So Amanda gave me quite a specific brief about what she'd like me to talk to you about today, and I've divided it up into sections. So from the first part, we're going to look at HIQA. Basically, it's mission statement, vision, values, what we do, and our structures. Because very often there's a lack of understanding about HIQA as an organization. And I suppose to put it in context, HIQA was devised back around 2007. And that was a time, if you'll recall, there was quite a lot of pushback to what we're seen as quangos and these government organizations that were being established. So within HIQA came together quite a number of bodies, and that was seen as a good solution to multiple different small organizations. But it does make HIQA quite unique insofar as it is a regulator that also has a function for setting standards, also has a role to play in health information. So look, the corporate statement, the corporate reporting, our 3-year corporate plans, HIQA was quite focused on transparency, and will always be very open about what it is doing and what it is setting out to do. And essentially, the mission statement across the organization is that it is an organization that's working to improve health and social care services for people in Ireland. And then our vision is set out as for providing safer services. So that's where we work to protect and safeguard service users, to ensure better care, work to improve the quality of health and social care services, aid in the making of better decisions. So we provide evidence and information to inform local and national decisions about services, and then independent assessment, where we provide independent information to inform decisions that are being made at a policy level. So just to bring them out a little bit more clearly to you, if I go back up there, our values are set out as well, where we put people first, we're fair and objective, open and accountable, striving for excellence and working together. So that's just to give you some context behind the ethos of the organization. And these next 2 slides, just pull them out a little bit more clearly for you. So within the organization, HIQA was established, and it had a board that came together, and this board is drawn from interested parties who probably have a history of service, public service, have a history in an employment history of maybe academia. Audit is an important function of the board. Brings in perspectives from acute healthcare and from social services, and also was supplemented with IT and HR background more recently. So the board of HIQA oversees the organization, which is run by the Chief Executive Officer. That until December, that was a man called Phelim Quinn. He retired in December, and our new Chief Executive Officer is due to take up the role at the end of this month. Under the Chief Executive Officer and sort of the corporate function, which oversees our HR, our IT, our OC Health, all those kind of functions that you'd have in any organization, you have 4 different pillars the Health Technology Assessment Team, the Health Information and Standards, the Chief Inspector of Social Services, and the Director of Healthcare Regulation. And this is what I was saying at the start, is this will be quite unique, where you would have a regulator of health and social care services within the same umbrella organization as the group that develop the standards which underpin the care that's provided in these services. Or where you have a function like health technology assessment. So my specific role is what we're going to come to now under Section 2, and that's the Office of the Chief Inspector. And the Office of the Chief Inspector is underpinned by the Health Act 2007. It's actually established under the Health Act 2007. And the role of the Chief Inspector is to oversee what are known as registered designated centres. And it's important, if I go back to the previous slide, sorry, you saw there that there was a Director of Healthcare Regulation. What many people don't often realise is that the HIQA's oversight of acute healthcare services, such as hospitals, is very different to its regulation of designated centres. In healthcare, HIQA can monitor the services that are provided. But in designated centres, registered designated centre, the Chief Inspector can control entry into the sector. So you have to be registered by the Chief Inspector to actually operate such a service. We have powers of enforcement, which I'll refer to briefly further on in this presentation, which are, so the Chief Inspector could stop people being admitted to a designated centre, could attach restrictive conditions to how a designated centre operates, and could actually close the designated centres. Those powers of regulatory enforcement are not in place for acute healthcare services such as hospitals. Just to refer briefly to the Health Information and Standards Division, that is this section that you'll be familiar with, who puts together the national standards for health and social care services. So from our perspective, that will be the national standards for designated centres for older people, the national standards for infection prevention and control in acute healthcare and designated centres. This division also operate the National Care Experience Programme, which is a tripartite arrangement with the Department of Health and the HSE. And you may have seen in the news yesterday that a care experience audit is starting for users of and residents of nursing homes. They've previously looked at experience in acute healthcare facilities. They've also looked at experience in the maternity services. The standards also look at identify deficiencies in Ireland's e-health landscape, and they have provided national recommendations to improve e-health. They've set standards for national data collections, and then they report on compliance against these standards. And just to say briefly, within the health technology assessment, they conduct assessments of health technologies, including drugs, devices, diagnostics, public health programs, and they help to inform health policy. They played a very strong role during the pandemic, the COVID-19 pandemic, where they were the source of a lot of the information that was provided to NPHET on everything, you know, from the wearing of masks to the different therapies that were evolving as we moved our way through the pandemic, to issues such as, you know, the need for separation in schools, etc. So a very broad range that was outside of those organizations that HIQA would monitor standards in, or that the Chief Inspector would regulate. So the Office of the Chief Inspector, was established under the Health Act, and the Health Act is basically sets out how we function. It sets out that the Chief Inspector can regulate designated centres for older people, designated centres for adults and children with disability, some children's services, and in the very near future, public policy is that it will regulate home care, albeit that hasn't started yet. So the Health Act is quite a long document, but which deals with all aspects of how HIQA functions. But the specific areas that are relevant to the Chief Inspector are Section 41. And what that says is that the Chief Inspector must establish and maintain one or more registers of designated centres. So Joe Public, who's thinking about looking at going to live in a nursing home, or maybe their family is thinking at looking at it, well, then there is a register on the HIQA website that they can just log in, you know, and look at nursing homes in their area. And that register will identify the name of the nursing home, the address of the nursing home, the registered provider of the nursing home, and some of the relevant bodies that are involved in the management of that nursing home. Section C of Section 41 says that the Chief Inspector must register and inspect designated centre for the specific purposes of assessing whether the provider is in compliance with the regulations and the standards that the authority sets. So keep that in mind. We register nursing homes. If you look at my area, we register nursing homes and we inspect nursing homes to see if they're compliant with the regulations and relevant standards. The Chief Inspector, although she resides within the organisation that is HIQA and is an employee of HIQA, she is actually independent of HIQA, such as the CEO and the board of HIQA, with regard to the regulatory decisions that she makes. She must report to the Oireachtas, to a committee of the Oireachtas, and can be called to account for decisions that are made there. So she has a normal employee-employer relationship with HIQA, setting of terms and conditions, you know, monitoring of annual leave, reporting of absence, that sort of thing. However, in relation to decisions made with respect to a nursing home, only the Chief Inspector can decide to cancel the registration of a nursing home, and she can decide to do that regardless of whether the board of HIQA or the CEO of HIQA agrees with that decision. The Chief Inspector and myself as the Deputy Chief Inspector have been called in front of the Oireachtas, different Oireachtas committees, in order to report, say, most recently on COVID in the nursing homes and the impact of COVID in the nursing homes. And, you know, that's, you get that request to report to a committee, you just say yes, and what time would you like me to be there? It's not an issue that you wouldn't be attending. So then Section 43 speaks to the inspectors of social services. And what the Health Act in this section says is that the Chief Inspector may appoint persons known as inspectors of social services. And that essentially, I'm an inspector of social services, and my entire team, with the exception of the clerical and the administrative staff, are inspectors of social services. And we carry with us warrants which show that we have been appointed in line with this section of the Act. And that warrant allows us unfettered access to any designated centre. So we knock on a door and a registered provider doesn't actually have the right to say, no, you can't come in. And this is grounded in the care and welfare, or concern for the care and welfare of residents of nursing homes, that there would be an independent body who could access a nursing home at any given time. Within this section of the Act, we are obliged, and the Chief Inspector is obliged, to maintain a scheme of determination. So within that scheme of determination, there are certain things inspectors can do. So they can inspect nursing homes, they can review information that's received, they can contribute to decision making. But an inspector or a regional manager, although they're inspectors of social services, couldn't make a decision to cancel the registration of a nursing home. They couldn't make a decision to attach a condition to vary a condition of a nursing home. Only somebody at what we call a DL1, a decision level 1, which is the deputy chief inspector or the chief inspector, can make a decision to take such action. So we have a very specific scheme of determination which sets out what each decision level, so we have an inspector, a regional manager, and a deputy chief inspector, can do. We do have to always identify ourselves. So, no matter how well we know the people in the nursing home, we will always produce our warrant on arrival in the nursing home. And we are also required to produce photographic ID saying that we are who is named in the warrant. Now, HIQA has combined all of those into one booklet, which we call our passport. And that contains a warrant, a copy of the warrant, and it contains, photographic ID as well. But it is perfectly acceptable for any member of staff who engages with an inspector during an inspection of a nursing home to ask to see that warrant. They're well within their rights to do it, and we would encourage people to do it. And even where we know people, you can say, look, we're going to cross the T's and dot the I's, here's my warrant, you can see it. So what this slide is showing is the sort of scheme of determining our delegation through my team. So we start with the Oireachtas or the state, the chief inspector, the deputy chief inspector, regional managers, inspectors, regulatory officers, and they are people who support the individual teams. They do have a regulatory function in that they can review information that's received. So they're not an administrative grade, but they don't generally inspect nursing homes. And then what I have down there as RST is our regulatory support team. They're our administrative and clerical staff. So they're the people who would engage with providers, sending back reports, sending compliance plans, sending in communication, etc. So just thought I'd give you a look at the team that inspect the nursing homes. And I suppose the most common reaction anybody who takes up employment in HIQA is, oh my God, I thought there was hundreds of you. There's actually not. Up until the end of 2020, there were 18 inspectors for nursing homes across the country. There were 4 regional managers, and there was myself. So everybody's reaction when they come in is, oh my God, is that all there is? Now, to be fair, in the expert panel that reviewed COVID and made recommendations on nursing homes going forward, recognized that. They recognized the assurance that was derived from inspections, and they recommended that the numbers of inspectors be increased. And as of the last count today, there are 27 inspectors for nursing homes. We also have national inspectors with expertise in infection prevention and control and fire safety, which work across the disability centres as well as the nursing homes, but they actually sit under my team, and that's what's referred to there as the National Operations Manager, the specialist team. We ultimately hope to get to 3 fire inspectors and 3 infection prevention and control inspectors. But to be clear, they're still inspectors of social services. They just have expertise in the areas of infection prevention and control and fire safety. So below that, then we have the country divided into 6 teams. We would like to have aligned those to the CHO areas, but actually given that there's 9 CHO areas, that just didn't work out. And anyways, we found out during COVID, the public health teams are not aligned to the CHO areas, and we would cross both in our engagement in relation to nursing homes. So we have DCOP East, which covers kind of Dundalk over into Cavan and down to Dublin. We have Dublin Greater, which is really inside the M50. DCOP South, which is Cork, Kerry, tips into bits of Limerick and Tipperary. DCOP West, which is Galway, Sligo, up that region. North, which is Donegal, Leitrim, Roscommon, and then the southeast, which is kind of Wexford, Kilkenny, Carlow. And within each of those teams, you have a regional manager who oversees 4 inspectors and a regulatory support officer. So our aim is to get to a situation where we inspect every nursing home once a year, and hopefully we get to about 50% of them a second time in the year. And we'd like to be in a situation where we're doing, shorter, more focused inspections, but in more often. We also, in the last 2 years, have stopped really doing announced inspections, because it became clear that really the public don't value them as an assurance mechanism. The policymakers don't value them as an assurance mechanism. And while we had put them in place to increase engagement with families, so by notifying families that we would be in a nursing home, we thought it would give them opportunity to come and meet us. It actually didn't translate into increased engagement with families. And then COVID and various visitors restrictions reduced that even more. So 95% of centres, 95% of inspections in 2021 were unannounced. 4% were short-term announced, which meant they got about 72 hours of notice, and 1% was announced. That was actually a centre that we went to that was being registered. So that came up as an announced inspection. So the regulation of nursing homes then is underpinned by a legislative framework. We maintain regulatory oversight, and I'll talk to you about what that looks like. Give you a little bit of a sector overview and a provider profile. So the legislative framework for the regulation of nursing homes begins with the Health Act 2007. But underpinning then that is a framework of regulations and standards. So regulations are the law. They're the minimum requirement for a centre in order for it to be able to function. And with respect to nursing homes, you have this SI number 415, which was dates to 2013. And in that, there are 34 regulations, and we call these the care and welfare regulations. They largely underpin the quality of care of residents living in nursing homes. There is also another document, which is the registration regulations. And that really looks at different things like the paperwork providers must provide, the fees they must pay, that sort of thing. Very important, necessary to get entry into the market and to be maintained in the market. But in terms of the quality of resident care, this document, SI number 415, is actually the important document. Then here, the standards, we have 2 sets of standards that are required or that inform care of residents in nursing homes. These are the national standards for residential care settings, and then equally the national standards for infection prevention and control in community healthcare settings that are dated 2018. Standards set out a vision for quality and should be what a service aspires to become. So the regulations are the bare minimum. You have to be achieving the regulations, achieving compliance with the regulations in order to operate. Standards are that quality pull, where you're moving your service on, and that's what many providers, even though sometimes you wouldn't believe it listening to the narrative in the media, there are many nursing homes that are focused on improving compliance with the standards. Bare minimum compliance with the regulations, they're not interested in that. As far as they're concerned, they achieved that years ago. They're really, grounded in driving their centres forward, improved quality of life for residents. The national standards for infection prevention and control are slightly different to these national standards, because Regulation 27 in SI number 415 requires compliance with the national standards for infection prevention and control. So there's a slight nuance there, that there's actually a regulatory requirement to be compliant with the standards on infection prevention and control. That's not there for the national standards. Now, that was quite useful during COVID, because obviously there wasn't regulations grounded in COVID, in dealing with COVID. However, the national standards require compliance with guidance from bodies such as the HPSC, which meant that we could look for providers to push through on the guidance from the HSPC, and we could link that back to a regulatory requirement. So providers who weren't implementing the HPSC guidance in relation to residential centres could be found to be not compliant with Regulation 27. The standards, just before I move on, the standards, legislation and regulations are intended to work together to assure quality and safety in nursing homes, in the service that the residents living in the nursing homes receive. So our regulatory oversight is affected through three real, pillars or arms. One is inspection. So any nursing home can be inspected at any time, any day of the week, by an inspector of social services. In 2021, we completed 555 inspections. And when I pull this data, which was at the end of February, we had completed 84 so far in 2022. I suppose 555, while it's a good total and will be in and around one inspection per centre, if you just took it on a number of centres. What we found in HIQA in 2020 and 2021 is our inspections were more resource dependent. So, our teams basically had to comply with travel guidance. They don't live near all the nursing homes. So at times there weren't hotels open. These kind of things became very real realities for the inspectors. So that actually translated into nearly 1,000 inspection days. And we would hope that we would be able to keep the number of inspection days and leverage that to more inspections in the next 12 months, because we won't have the same need. Also, there were some nursing homes in such crisis that, one inspection of a nursing home might have taken 9 inspector days, because we would try and send, if there was an outbreak, we would try and send an inspector in. So there'd be one to go to clean and one to go to a contaminated area. If we couldn't do that, they would go to clean first and finish up in the contaminated area. But if possible, we'd send an inspector to both sides. But we had some centres where we were so concerned about the care of residents, we would go back in 2 days later, or we might go back in a week later. And some inspections, we had to go back into those centres on 3 occasions within a very short space of time to be assured that the residents were receiving the right type of care. And that really, we translated that into one inspection report where we tried to be very balanced and tell what we found on the first day that gave rise to the concerns, give fairness to what was achieved over the space of the 2 to 3 days. But actually, we couldn't stop going back in there until we decided, well, actually, we're closing this place, or the residents are now safe and the care they're receiving is acceptable. Aligned to that, we have notifications, and the Health Act and the associated regulations requires providers to notify us of very specific incidents. So they're legally mandated. We have some of them are registration relate to the people running the centre, but we have notifications NFO1 to NFO9, which are related to the care and welfare of residents. So an NFO1 would be a notification regarding an unexpected death of a resident. An NFO2 would be a notification regarding an outbreak. An NFO3 would be a notification regarding an allegation or an incident of abuse of a resident. And they go on up, they look at, referral to a professional body, fire in a centre, disciplinary action of staff. There's a number of them there. They have to be notified to us within 72 hours of an event happening in a nursing home. For COVID, the Chief Inspector issued a guidance saying that any resident who dies with COVID was to be notified as an unexpected death. Now, we do recognise that many residents who sadly passed away with COVID were very much at end of life. and probably were going to pass away in the coming days and weeks. However, in order to have a true picture of the impact of COVID of any given time, we felt that this was necessary, a necessary action that could be taken. The Chief Inspector is not the holder of definitive data. The HPSC is the holder of the definitive data with regard to deaths related to COVID. But it just gave us an indication of the impact of COVID in nursing homes, highlighted nursing homes that might benefit from a visit, and also where the resources the HSE had available could be targeted. So in 2021, we got 17,909 notifications, and 3,500 so far in 2022. And just to put it in perspective, every notification that comes in must be read, reviewed, and risk rated. So we would say, so now there's a small number of registration notifications that we don't review and risk rate, they just change the data that's available on the Chief Inspector's register. But the vast majority of them, we read it, we have to see whether, it says something about what we know about that centre. Is there a trend to be seen here? Do we need more information around the processing of it? Do we just say, okay, we're going to close that and we're going to make a note that this is something we have to follow up on the next inspection? So you can imagine 17,000, that's quite a lot of work, and people often say to us, I thought all you did was inspect. But a lot of information is available to inspectors before they go out and inspect. Receipt of information is similar. It's not legally mandated, but it is a facility that's available to anybody. Anybody on this talk today could pick up the phone to HIQA and say, I want to make you aware of a concern I have, or I want to share information I have about a nursing home. We call that unsolicited receipt of information, and we see that as a very valuable resource in relation to how nursing homes are operating, because it often reflects the lived experience of nursing homes. Having said that, we also recognize it's unvalidated information. It is one person's perspective of the service that they have received, and it is always viewed from the system's perspective. So you'll hear politicians saying that HIQA can't investigate individual complaints. So if somebody rings and said, I'm concerned that my mother is dehydrated and not receiving proper food in nursing home A, we won't look at that from the perspective of my mother, but we will look at that from the perspective of the nutrition and hydration of all residents living in that nursing home and what it might tell us about that. And, we may take on the basis of that information, go back to provider and ask them to provide us information with regard to the meal times, maybe their staffing levels, maybe their dietetic reviews, their access to speech and language therapy for swallow assessments, all that sort of thing that might impact on, how residents are getting nutrition and hydration in that particular nursing home. So it won't be from the perspective of my mother, of the person who made the complaint, but we will use it to inform our regulation. So while the components haven't changed, so these are the three components: inspection, notifications, and receipt of information. Over the course of the last 10 years, there has been some changes to how we present that information. So in essence, our inspection reports. And in 2018, we tried to make the report more user-friendly. We used to present our reports as grouped regulations under outcomes. And actually, when you sit back and you look at it now, you think, why did we do that? How did that ever make sense to us? But like any organizations, things make perfect sense at a time, and then you move on. So now what we do is we've combined the regulations, the 34 care and welfare regulations, under two headings: capacity and capability, which speaks to the governance and management of a centre, and then the quality and safety, which speaks to the lived experience of residents living in the nursing home. But before we even get into that, we have a section where we say what we saw and what we were told. And that's where we try and present the voice of the resident in the nursing home. And we would like, as we progress, to see that section become the longest section of an inspection report. We have a very varied audience for our inspection report. We have the residents, their relatives, people who are shopping around for a nursing home for maybe themselves or a relative, the policymakers, the service providers, you know, quite a broad, the people who pay for the services. There's quite a broad audience, and it can be hard to have a single report that feeds all those needs. But the most important thing to us was people, the public were telling us, we actually can't understand what you're saying in your reports, which was a difficulty. So that's why we've tried to break them down into, you know, what we saw and what people told us, and then give a snapshot of the overall management of the centre and a snapshot of the quality of care, while at the same time making it very clear to providers under which regulations we found breaches or we found good compliance. And there are a number of centres out there that are regularly fully or nearly fully compliant with the regulations they're assessed against. So a quick overview of the sector. With regard to nursing homes, in 2009, there was about 600 centres. So this is when HIQA came into being and first started to register and regulate nursing homes. And I suppose it's important to note that before that, the HSE was regulating nursing homes. So it's not like the sector wasn't used to some level of regulation. TRISA might have never figured out how many residents were living in nursing homes at that time. I'm sure it's out there in a document somewhere. I've never found it. In 2012, there was about 28,000 residents living in 575 centres. In 2018, that had increased to 31,250 residents in 581 centres. And at the end of last year, there was 31,842 residents living across 567 centres. Now, I suppose, unfortunately, what those figures are saying to us is we have less centres, more residents, and the general trend at the moment is to move towards bigger centres. And the centres that we're sadly losing are the small mom and pop family run centres. In the last 2.5 years, the two smallest centres in the country closed. One had 9 residents and one had 13 residents. They're not viable services. They're often accommodated in buildings that won't meet the regulations or don't meet the regulations since the 1st of January. And a cost benefit analysis on any level would show the finance that will be required to bring them up to compliance won't be offset by their future financial earnings. So you can very much understand why people are making these decisions. But bigger is not necessarily better. And I suppose if you contrast what's happening in the disability centres, where there's a public policy towards decongregation, I'm always saying we'll have decongregated the disability centres. By the time we've all that done, the residents will be moving into nursing homes, back into centres of about 150 people. And the numbers of centres with over 100 beds is increasing. There's no impediment to any size of a nursing home in Ireland at the moment. And I know that's something that the Department of Health is currently looking at. In the UK, it's the Department of Planning and the Environment that restricts the sizes of a nursing home. But really, if somebody was applied tomorrow to register 500 beds, if those 500 beds were compliant with the regulations, we would not be able to refuse registration of that centre, even though we might be saying, who wants to live in a 500 bedded home when you're in your late 70s and 80s. I suppose the profile is also changing a little bit. In 2012, private providers ran 411 of the nursing homes, public providers 115, voluntary providers 36. And by the most recent figures at the end of 2021, the biggest change has occurred in the voluntary providers. That's now down to 17. And these were very often voluntary boards run by charities. And actually, you know, you can understand why they have discontinued. You know, you very often had people in the local community, and the level of responsibility that they had for the operation of some centres was huge. They were actually legally responsible for the care and welfare for, you know, maybe 60 residents. And these were people who may, as they said themselves, I signed up for a few fundraisers, But the reality was when they came to it, they didn't have the expertise. And to be fair to them, they recognized that, and they recognized that they weren't providing the best level of service for residents. So many of those have now transitioned into companies, unlimited companies, and they have structured themselves so that they nearly run like a private provider with a board, with the expertise that's required on the board. The number of public centres has reduced, and that is largely to do with the impact of COVID, where the HSE made a decision to repurpose a number of their centres. It is also to do with the new regulations that came into effect on the 1st of January, that many of those repurposed centres were actually centres that weren't going to be compliant with this physical premises. They had Florence Nightingale type wards, didn't have enough bathrooms, didn't have enough communal space, these kind of things. And they recognized that these centres could actually provide a much better, different type of service that was equally needed by the health service to look to decanting acute hospitals. So when that happens, when they're deregistered, what we do is we notify the healthcare team within HIQA, and they begin to monitor against the standards for safer, better healthcare in these facilities. So it's not like they go off the radar. They're not regulated because they're no longer a registered designated centre, but HIQA does still have a role of monitoring compliance with the national standards for safer, better healthcare in those services. I think the next slide, again, just the number of beds. So there's over the last 3 years, while the number of centres have changed, as I've said previously, there hasn't been a huge difference in the number of residents. So we're in the 5th cycle of regulation. And what that actually, the message there is, registered providers of nursing homes are well used to regulation. They have, I suppose, they know what's expected. A lot of them have been in the system since the very early days, and they've transitioned through with the transition in the regulations that has occurred over that period of time. And we would hope that, there'll be a level of stability come into the market at the moment. We do see that there's a lot of external financial interest coming into the market, and conglomerates that are in receipt of significant overseas funding are buying up individual nursing homes. So this can be done by one of two ways. They can either just buy the nursing home and apply to become a registered provider themselves, or they can buy the registered provider that runs the nursing home and become the provider by a change of directors. And that's actually the one that's most often done. So we don't always have very clear sight of those changes that are happening in the market. The CCPC has a role to play here, because some of these these transactions are of such huge monetary value, they require to be notified to the CCPC. And look, at this stage, it is not clear whether this is going to be a good thing or a bad thing for the service. It may well be a good thing. It may bring greater standardization. It may bring finance into a sector that, some of the buildings require significant upgrading, and we have seen commitment from some of these providers coming in to do that. Only the rear view mirror is actually going to tell us, because of course the concern is, will there be economies of scale, and will this drive down standards in nursing homes? To be clear, to date, we haven't seen that. But it is something we're very watchful and mindful of. I suppose it's probably a bigger risk for the funding model, because the power that's a particular group, if they control 2,000, 3,000 or 4,000 nursing home beds, then their leverage is much greater when they go to negotiate with the National Treatment Purchase Fund. And I think that's something the policymakers are very mindful of. There's absolutely nothing wrong with how they're doing it. It's perfectly legal. We live in a democracy with a constitution, and the constitution allows people to, buy and sell business. But it does raise questions for the future funding model. And if one provider was to say, well, I'm not going to engage with Fair Deal, that might give them very significant leverage that individual nursing homes didn't have in their own right. But again, like I say, it's the rear view mirror is actually going to tell us these things. At the moment, we are just conscious of a need to maintain regulatory compliance and quality of care on a day-to-day basis in the nursing homes. So I thought inspection would be an area that you'd be particularly interested in terms of what our inspectors look for in relation to when we go in and we visit a designated centre. I suppose just to put it in context again, an inspector, an inspector of social services within the office of the chief inspector within HIQA has the right to enter any nursing home at any time. About 3 years ago, we engaged with our providers and we asked them to give us feedback. And one of the things they told us is we were very predictable. They always said, if we haven't seen you by Thursday, we know we're not going to see you. And if we haven't seen you by 10 o'clock, we're safe enough for the day. And I was sitting listening to this and I thought, oh, cripes. So we went and we pulled the data and they were right. We did very few inspections on a Monday or Friday, never on a Saturday and a Sunday. And most of our inspections went from 9 o'clock in the morning till 5 o'clock. So since then, we have taken a more creative view to how we inspect. We inspect across the 5 days of the week. We do more out of hours inspections. And we have on a small number of cases, inspector centres on Saturday and a Sunday. And that would be where we'd have very serious concerns, maybe about staffing or governance and management of a centre out of hours. If we've maybe seen a trend of falls that are coming in that are timed at weekends or at night duty, or if a family member or a staff member has raised concern, that might be something that we would look at there. So why do we inspect? We inspect for the purposes of safeguarding residents, providing an independent objective assessment of performance, identifying areas of good practice, identifying areas of poor practice, sharing learning to drive improvement, and helping to create a culture of continuous improvement. There are what our aims when we go out to inspect. We try and ensure that our inspections are grounded in fairness, respect, equality, dignity, and autonomy, and that our review of residents' life is grounded in these principles as well. I'm going to have to speed up a little bit here, just simply by virtue of the timing. So apologies, I'll just give a quick overview of some of these slides. Residents, when we look at dignity, what we're actually looking to see is that the residents' right to dignity is being upheld. That, that there aren't unconscious institutional practices, that residents, that there isn't an expectation that a resident will have all their care provided at the bedside simply because it's easier to do that. That, people working in nursing homes are aware that everything they say can, if they're in a multi-occupancy room, will be heard by everybody else in the nursing home, in the room at that given time. And that may not be appropriate. That the residents' rights to bodily integrity are upheld. We're looking at practice like covert medication. Are they being facilitated to live as fulfilling a life as possible? I met a lady with Down syndrome in a nursing home. She's been there, she's 44 and she's been there for 2 years. Before she went into that nursing home, she used to attend national conferences. She worked in a laundry service, in a daycare service, and she was integrated with her local community. Since going into the nursing home, she lost all of that. These are issues that we would be looking for when we talk about the dignity of residents. Autonomy, healthcare of any sort is a risky business. And while we expect providers to manage risk, we also expect them to allow residents to take part in, risky activities if that's what they want to do. We encountered a resident recently who the provider had told her she couldn't go across to a hotel with her visitors for afternoon tea because she was at risk of getting COVID. that resident was as able as you or I were to decide whether she wanted to take that risk or not. And it was really working with the provider to explain to them, yeah, you've the right to manage risk, but only in the context of you fulfill their residents' rights to their own autonomy over their own action. And I don't say it lightly. I understand the challenge that poses, but it's a challenge that register provider has to be able to manage and has to be able to meet. Equally, families, we frequently get families contacting us saying, I want the nursing home to put the bed rail up on my mother. She keeps falling. But her mother has said very clearly she doesn't want a bed rail up in that nursing home. And her mother, it's working with the family to make them understand that you don't have the right to say this. It's this whole next of kin. Well, I'm the next of kin, so I want them to do this. They're very difficult conversations to have from the provider's perspective. And it's going to take a huge cultural shift in us as a society to make that move away. But it's conversation has started, and that's the main thing. Choice. Are residents asked, what's an enjoyable day for you? What do you want to do? Just because you're in a nursing home shouldn't preclude you from accessing your community. Is there quality care planning? And is it a living document informed by the family and the resident? So starting with the resident, and where the resident doesn't always have the capacity to really say what they enjoyed beforehand, do the families get input into it? So if somebody never watched television in their life, having an activity that is a television on in the corner or the rosary blaring over the radio is actually probably not something that they want and cannot be interpreted as a meaningful activity for that person. But if somebody has spent their life knitting for the kids in Chernobyl, then it's not right for you to take their needles away because they'd be safer without them. This is where you're balancing autonomy, dignity, and choice. You're not going to get autonomy, dignity, and choice in the absence of good governance and management. And what we're looking for there is, do the management understand the concept of person-centered care? And how do they translate that to the people working in the service? And how do they manage the challenges? And some providers are excellent at this. They really are, and to be fair to them, even where regulation might have been in previous years viewed as a challenge, they found their challenges around it. Like one provider talks about the dog they had in the centre back in the very early days of regulation. And the inspector apparently was worried that it might be a slip, trips and falls risk for the residents because of the colour of the dog and the colour of the flooring. So the provider changed the color of the flooring and the dog remains walking around the center. I said, fair go to you. That's the kind of provider who's really grounded in the care of residents and fulfilling the rights of their residents. Good communication. And COVID really put this in perspective. Some centers are still bearing the fallout from when they lost sight of good communication with the families. They were so challenged by the extent of the outbreak in their center. All their energies were going on managing the center. Phones weren't being answered. There was a vacuum of information for families. And where that vacuum existed, anxieties arose. And, from May 2020, one of the key messages we began to share with providers was, don't lose sight of the external message. No matter how bad the outbreak is, tell your families, tell your residents, let them make their own decisions. If they want to bring Mammy home for the duration of the outbreak, let them bring Mammy home. That's their choice, as long as it's Mammy's choice as well. And be very upfront. We're short of staff. We're not going to get to answer the phone every time you ring. We'll send a text every morning. We'll send an email every day. We promise you, if your relative's condition deteriorates, we'll be in touch with you. And, those centers that learned those lessons, no matter how bad the outbreaks no matter how many deaths there were in their center, they never lost the confidence of their families. And that was really a key message. But actually, we need to take that beyond COVID and use it to inform all aspects of our operation of designated centres. Social interaction and personal relationships. Look, there's a core group of centres where the residents are minded within an inch of their lives, but they're not allowed to move out of the chairs. You know, I was in a centre one day, it was one of the hottest days in the summer of 2019, and there was a beautiful outdoor garden. There was 2 residents outside there chatting out to people who walked past the garden. All the 2 boys were short. It was a pint of cider and a 99. And inside in one of the rooms, there was a woman who wanted to get out into the sun, but she couldn't go because she might fall. You know, so it's about allaying the staff's anxieties and getting them to understand, well, if you're worried about her being falling, then you need to be out there in the sun with her, not keeping her in the room where you're happier writing your notes, you know. So that's right. It's about the residents' voice being heard and being upheld. Active living, you know, we spoke about that, meaningful activities. The rosary on in the corner at 6 o'clock every evening is not a meaningful activity. Yes, it's something that a lot of residents really want and really appreciate, but it can't be their sole activity for the day. And that's why it's about engaging with providers. It's about engaging with residents and also recognizing those residents where group activities are not appropriate. Group activities work for a significant proportion of the residents and they love them. They love the bands coming in, they love the fire arranging, they love the cooking, all of this, but it doesn't work for everybody. Following an inspection, then we will give the provider feedback. We'll give them provider feedback throughout the entirety of the day, and then we'll give them formal feedback at the end of the inspection. We then have a process of, you know, it's due process, and it can, you know, our inspection reports take about 4 months to turn around from the time of inspection, because we send out a first draft, we invite them to give us feedback. We make amendments if it's appropriate, and then the provider has the ability to engage in a challenge to our regulatory judgments, which is an internal process that's heard by somebody other than us. Than the DCOP team. And then by the time you go through all of that, I think I might be under pressure here, lads. Look, they're letting me know that I'm needed in the other centre, in the other area. But look, we then proceed to a stage 3 report and a publication. I suppose it's just to give ye feedback that, you know, there is due process. Providers do have a right of reply. Staff in centres have a right of reply. But at the end of the day, the inspection reports reflect our findings on inspection. The Chief Inspector has significant regulatory powers. Under sections 50, 51 and 59, she can attach conditions to the registration, can vary existing conditions, or can cancel the registration of a centre. And I suppose, in essence, 50 and 51 are very similar. 50 happens at the time of a renewal of a registration. 51 happens in the mid 3-year process, so it's outside of that application. The difference between 59 and 51 is the slow walk and the fast run to the court. So section 51, we issue a notice of proposed decision. They have 28 days to respond. We have to go out and inspect and see what their response is, issue a notice of decision. They have another 28 days in which they can challenge, after which they can challenge it in the district court. Section 59, we've bypassed all that. We've gone straight to the district court and asked the court to cancel the registration. So, you know, the power most often exercised is the attachment or variation of conditions. The nuclear option is the cancellation of registration, and we don't do that lightly. We are literally putting people out of their homes when we do that. So there's only been 2 section 59 closures since I took up this role in 2016. There has been 4 closures under section 51. Those have all actually occurred in the last 18 months. And then we have also issued 4 section 51 notices of proposed decision to cancel the registration, which were later withdrawn, because when we went out and inspected, we saw enough progress that we thought, well, we'll hold on the notice of decision. We're not withdrawing the notice of proposed decision. We'll afford you an additional opportunity of time. Some of those notices remained live for 12 months. But in essence, at all times during that 12 month, the provider was demonstrating they were on a trajectory towards improvement. And we were prepared to give them that opportunity, mindful of the fact that these were people's homes that we are talking about. The fit provider, we have an assessment of fitness, that's their compliance with the regulations, the integrity of the provider, their engagement with their residents, and that underpins our actions under section 50, 51 and 59 of the Health Act. If you're a fit provider, it's very unlikely you're going to find yourself dealing with a section 51 or 59. And then the persons in charge. There are very specific regulatory requirements about who can operate an inspection or a designated centre for older people. The person may be a registered nurse, should have 3 years experience of nursing older persons in the last 6 years, not less than 3 years experience in a management capacity, and post-registration management qualification in health or related field. Now, there's currently a process of regulatory reform underway, and we would see some of the regulations. We think that will be streamlined. We've made representation asking for it to be streamlined. At the moment, you can get a level 5-day management qualification that meets the regulatory requirement, but a module at postgraduate diploma level doesn't constitute a management qualification. So we would feel that there's room for the department to change that regulation to make it more meaningful. So we're engaged with the Department of Health in relation to reforming the legislation and reviewing the regulations. We're also focused on the implementation of the recommendations of the expert panel. And we're also focused on the Ombudsman's report on under 65s living in nursing homes. And we would see this as something that we'll be focusing on as we emerge from the COVID-19 pandemic in nursing homes. So that's it, folks. That was the extent of what I was going to share with you here today.
That was wonderful.